This is Dr. Noman Siddiqui providing the description of correction on this lateral foot and how to utilize TraumaCad and deformity planning as well as correction. Earlier we had talked about a bunion deformity. We're moving on to a different image which shows a soft tissue as well as a bony deformity that many foot and ankle specialists commonly encounter, and that is of a flat foot deformity. This patient, and in this image you can clearly see there is a flatter foot deformity with the increased talar declination and somewhat of a equinus component. And I would like to describe how I use TraumaCad and in correcting the deformity, as well as understanding what I may encounter in the operating room. And that's why I feel this is a very nice tool in planning as well as demonstrating to the patient what they can expect. So the first thing first, you always have to select the image, and once the image is in your screen, you have to press next. And because we're doing foot and ankle surgery, we're going to select the foot and ankle. And the most important step obviously is identifying our image, which we said earlier is a lateral image, and we're doing the right side. And the best part of this image is that our radiology technologist has been very good and put a mag marker in here, which is about 2.54 centimeters for our European friends, and as well, or we'd say 1 inch here in the US. And that's a very good first step before you ever do any deformity planning on this program. Next, we make sure that's what this is, which it says 25.4 millimeters, and we press accept. In this case, we're not going to utilize really any of these options that are available to us, because the program itself allows you to be very flexible in how you use this program in deformity correction. And how I use it in the foot is I just use this main line right here, or this main tab up top, which is the interline angle. And there's certain foot and ankle measurements that those that are performing foot and ankle surgery are very familiar with, and I'll describe some of those before we do any correction. Most commonly, there is an angle that is used on the lateral view, and it is called a Meary's angle, or a lateral talo-first metatarsal angle, and that is identified by finding the bisection of the talar declination and the shaft of the first metatarsal. In this image, it measures out to be about 37 degrees. And what is normal of Meary's angle? Normally, normal Meary's angle is between 0 to 8 degrees on an anterior-posterior view, but on a lateral image, normally this angle is either parallel with where the long axis of the first metatarsal and the talar declination is parallel, with minimal to no break. When you start seeing a break, that obviously signifies a collapse of the medial column and a flat foot deformity. Conversely, obviously, if there's a dorsal apex of the Meary's angle, that's commonly seen in a cavus type foot. So in this instance, we see a 37-degree Meary's angle on the lateral view. And another angle that's common in foot and ankle is a calcaneal pitch. We can see in this patient there is no calcaneal pitch, and maybe even negative, but let's measure it out. And if we measure it out, it's pretty depressed. It's about 2 degrees. Normal calcaneal pitch can be anywhere from 15 to 24 degrees, depending on what you're using as your guide. But in general, this is clearly a depressed calcaneus as well as a collapsed medial column. Some of this can be caused by a soft tissue contracture, which is commonly seen in this deformity, which is known as an equinus position. And I will also show you how you can use this program to determine what kind of soft tissue correction you may encounter in the operating room. And that's where this program is best utilized. It's utilized as preoperative planning, so when you enter the operating room, there is minimal to no surprises, and the surgeon can tackle what he or she may encounter because he's had a good operative plan and has planned for contingency operations in the event certain things aren't corrected by the index procedure that he or she may be attempting. So now that we have a general idea that our angles are not accurate, we can go on and see how we can correct them. Well, the first thing we can do is work on how we can fix this Meary's angle. And most people, when they go into the operating room, they will see this type of patient and want to do a soft tissue type correction. And that usually involves performing a Achilles lengthening of some sort. That can either be at the attachment of the Achilles tendon to the calcaneus in the form of a hook or a triple hemisection of the Achilles. It can be done more proximally at the gastroc-soleal aponeurosis in the form of either a bulpius or even more proximal to that as a strayer. And it can even get as high as into the mid-calf or in the gastroc region as a Baumann, and if you start going up towards the knee as a silver scoid release. But how does one identify which procedure is best and will give he or she the correction? Well, I use this program to correct my deformity, and then depending on the deformity or how much of that deformity is corrected, I have a general idea of what procedure I'm going to choose. And this is more objective data as opposed to someone saying, hey, I always do a hook, or I always do a triple hemisection, or I always do a strayer, what have you. We can actually have a accurate, objective measurement as to why we perform a certain procedure. So the thing we're going to correct is first basically the calcaneal pitch and the talar declination. So I'm going to hit the inner line angle. Sorry, I'm not going to put that in the talus. I'm going to put that right here, showing the calcaneal pitch. And instead of moving it all the way down, I'm just going to move it to the weight-bearing surface so I can include it into my correction. So we said it was 2 degrees, and there we are, 2 degrees. Now, the fragment that you need to identify is the talus and the calcaneus, and you start off by clicking Define Fragment, which is on the top of the toolbar. And as I said, when you correct this, you want to go through as many data points, especially when you're going through an articular area. And we're going to start off right here on this articulation of the ankle. And we select all these data points, and we go around the calcaneus. And I like to include those lines for the calcaneal pitch into my correction site, and then head back up towards the articular surface of the talonavicular joint, because we're going to be rotating the talus, and then place it and close it off. Now, as you scroll over your fragment, you see that the center of that, or the bullseye red dot that shows up, is the rotation point. Because we selected around 2 joints that are used in this correction, we kind of serendipitously end up at the lateral process of the talus. And you can see here's this red dot, and it's right at the lateral process of the talus. And that is commonly known as the hinge point of the ankle and the rotation point of the ankle. So in our example, this has worked out nicely. We're going to rotate around the lateral process of the talus and achieve our correction. So you can move these lines and put them outside of your correction point, because we are going to reference the ground, and so the ankle is going to correct with reference to the ground. So if you have one line that's outside of the correction point, or the fragment that you're correcting, and one line within the fragment, you haven't changed your angle because that's still the same, 2 degrees, and you leave that because as we correct our deformity, the angle should change. And let's do that. So if you click our fragment, you come up here and grab the handle. Let's correct this ankle. So we said at least 15 degrees is normal. So let's get to that 15 degrees. And as you can see, as I'm rotating this ankle starts to look more normal. Right about 18 degrees, we're like, okay, so our talus is starting to have a more normal inclination. And let's keep going. I want it to be a little better. I want this patient to have a little more rotation. And now we're at 20 degrees. We split the difference between 15 and 24. And I'm much happier with this. Now we have a 20-degree calcaneal inclination, and the ankle is in a much better position than it was before. And so what does that mean though? How does this help me from a soft tissue correction standpoint? Well, once I put the talus right where I want it, I go up here and I grab my ruler and I use this gap that's been created to measure how much lengthening of the Achilles is really going to occur from the calcaneus. We all know the Achilles attaches to the calcaneus right about this proximal part, and it measures about 18 or so, 18.4, 18.5 millimeters. And that's an important point, because now if we start thinking about it, if we did a triple hemisection down in here at the level of the Achilles attachment to the calcaneus, we can easily over lengthen this and make this 20 millimeters or 24 millimeters and result in a secondary problem for this patient, which would result in weakness and what have you. And the better procedure for this patient to me would then be, let's not do it at the Achilles, let's move it more proximal, maybe at the gastrocoxoleal aponeurosis, maybe a strayer, and as we go more proximal we'll get less correction, but I will know that I'm less likely to over lengthen this patient if I go more proximal. Because if we hit this again and we go back to 15 degrees, you can see that that number changes. It's fluctuating. So naturally, if you want to correct this patient to only 15 degrees, all you need is, which we said was normal, 3 millimeters of length to get this to 15-degree correction. And that would just mean we maybe need a Baumann or a strayer. So like, we're going to keep this patient at 20 degrees and obviously we've decided that our soft tissue correction is going to be done more proximally. So we can stop at that. All right, let's adjust our lines. Make it back to 20 degrees, because now that this line is in the center of that fragment, it keeps adjusting, so you always have to be mindful of that. All right, so 20 degrees is that. So once we've accepted that we're going to correct our deformity to 20 degrees, we have to still address the forefoot. So how would you correct this? Now we can see our forefoot is not in good alignment here. So if we draw our lines again, we see that we have our bisection of our first metatarsal and the bisection of the talus is better than before. It was 37 degrees before, and it's now 18 degrees. So that just means our talus is in a better position. But how can we make these more parallel? Well, another procedure that's commonly done for correcting flat foot deformity is done through the medial cuneiform. And that is a cotton osteotomy, which is a opening or closing wedge osteotomy. But for interest of demonstration, what we would like to do is perform a opening wedge osteotomy to see if we can plantar flex the first metatarsal so it can be in line with the talar declination. So how would you do that? Well, you would select the defined fragment and come to the level of the middle cuneiform, which is right here, and the osteotomy is a through and through osteotomy of the middle cuneiform in a vertical direction that is in line with the declination of the cuneiform. So we can see the cuneiform is declinated this way, so we're going to make a vertical osteotomy and then identify our fragment that we're going to move. And as you can see, I'm selecting that fragment, and we're going to come back and close that off. Next, we're going to select this fragment and going to make our correction so we can reduce this 18-degree angle to a 0-degree angle. We've taken our bullseye, and where are we going to put this? We've decided we're going to do an opening wedge osteotomy, so that means it's going to hinge on the plantar cortex of the middle cuneiform. So we're going to put our bullseye on that plantar hinge and rotate the handle until we start getting a more corrected position. And as you can see, as I'm doing this, I can correct this angle all the way down to 0 degrees. But we don't want to create too much of a high arch. We just want to make a normal foot. So we'll just keep this between 0 and 5. So this patient has a relatively normal foot. And as you do this, there's a gap that opens up. The nice part is you can just grab your ruler and measure that gap. And this tells me that to get this much of a correction, I need a 7 millimeter either graft or opening wedge plate or distraction to make this correction. And now we have a more parallel looking line with a foot that is in a much better position than when we started off with. So this, again, illustrated soft tissue and bony correction and how you can pre-plan all of this before you ever enter the operating room theater and have an effective plan in addressing this deformity.